each year there's a different initiative that we can focus on. So far 43 countries across the world have taken part in this. Of course, we are one of them. So as I said, each year is a different focus, a different initiative. We can target the public, we can target families, we can target secondary care, primary care, healthcare workers. So the picture in the bottom right is one of our kids' family public engaging initiatives that we did a couple of years ago, where we painted rocks with pictures of bugs and we hid them all over Tayside. On the back of the rock was a Facebook page and a Twitter feed, and it was stewardship messages, and we asked people to post pictures of them or to hide them again around Tayside. And I think we actually got a rock in Paris at one point. So we did pretty well. And the point of European Antibiotics Awareness Day, which came first, is that now World Antibiotic Awareness Week falls around about that. So that was set up in May 2015. There was a World Assembly and it endorsed a global action plan around antibiotic resistance. And what that did was it encourages best practice among general workers, the public, policy makers, and World Antibiotic Awareness Week was rolled out off the back of that action plan. So this is our current Scottish campaign. Did everybody get a pen as they came in the door? There's leaflets, there's, if you want to take back to your clinical areas, please feel free to take pens away with you. So the current Scottish campaign is Get a Grip, and it stands for Guidelines, Review, IVOS, and Personalise Your Antibiotic Therapy. So hopefully the title of the presentation has become a bit clearer now. It wasn't just us hurtling abuse at you all when you came in. So guidelines, I think we do really well in Tayside. The review is probably something we can work on. The IVOST, again, I think we can all do that a little bit better. And personalise, so de-escalate and discontinue if appropriate. That's something that we're focusing on. So that is the current campaign running across Scotland this year. So in 2016, the UN called a General Assembly to combat AMR worldwide. Now this was hugely significant. That was only the fourth time in the history of the UN that a General Assembly was called. We've only done it 3 other times with a health topic. It was HIV, it was Ebola, and it was non-communicable diseases. So it was a huge deal. And world leaders agreed to address AMR in humans and animals, which was significant. That was the first time that we started to look at antimicrobial resistance from a One Health approach. So the health of people connecting with the health of animals, and more importantly, the health of the environment that we all live in. So that was quite novel at that point. In January this year, the UK government published 2 documents. It published our 5-year action plan. Now, we'd had a previous action plan, 13-18 action plan, so this was the new one that they published. They also published a 20-year vision for the UK. Okay, and within the 5-year action plan, actually within the second or third paragraph within the action plan, it gave us a target from within the UK. It asked us to reduce UK antimicrobial use in humans by 15% in the next 5 years. Whether we can achieve that or not, we'll see, but that's quite a feat. Now, we've had action plans before. We've had SCOT-MRAP, we've had SCOT-MRAP 2. That formed the Scottish Anti-Microbial Prescribing Group and our current stewardship group and work stream across Tayside. So we've had an action plan before. The difference this time is, this is the first time that a 20-year vision had been published. So the UK government for the first time acknowledged that this is a longer term problem. This is not going to be fixed within the next 5 years. Okay? It started talking about One Health, animal use, environmental use of antibiotics, and it very much focused on a collaborative and sharing focus within that. There is resistance issues with all kinds of organisms, bacteria, fungus, parasites, but for the purpose of these action plans, we're going to focus on bacteria and, more importantly, gram-negative bacteria. So that was the focus of them. Just to focus a little bit more on the One Health approach to AMR. So this was one of the images that were in these reports, and it kind of allows you to see where antibiotics can enter either human use, animal use, the environment, the water. We excrete meropenem out in our urine 70% unchanged, so that goes straight into our water supply. There's pieces of work going on right now around the coastline of Scotland looking at ESBL, E. coli, and how much of that comes into our water supply and how much we ingest. So that work is being done, and this is the first time that that is being looked at by the Scottish Government. Okay, so it very much is looking at it from all aspects. So that is the three main parts of the UK five-year action plan. It focuses on reducing the need for unintentional exposure. It asks that we optimise use of antimicrobials through lab capacity and surveillance. And it also asks us to promote innovation, supply and access for diagnostics. And it asks that we do that in humans, animals and the environment. Okay. So within the Scottish group, a group was set up that reports directly to the Scottish Government, and it's called the SONAAR group. And they are responsible for looking at all the resistance data across Scotland and sharing that out with boards. So the SONAAR report was published about 10 days ago, and it was the annual report for 2018, and it gives us an idea of how, as a country in Scotland, we are doing with antimicrobials. Here are the key highlights. So overall, in Scotland, antibiotic has decreased by 6.2% in the last 5 years. That's just in Scotland, but that's miles away from the 15% target that the UK government has set us. 58.5% of antibiotic use was access antibiotics, and I'll go on to that a little bit later on. If you look at how antibiotics are broken down within Scotland, it's no surprise that primary care comes out on top. It's been like that for a few years now. What is nice to see as a pharmacist is for the first time we appear as the little navy blue dot at the top as pharmacy prescribers. That's the first time we've appeared as on a report like this, which is quite nice to see. Primary care. I don't know if any of you spend time in primary care or work in primary care, but just again, highlights from primary care. 10.2% decrease in use over the last 5 years. That's absolutely brilliant. That's really positive. 27% of the population had at least one antibiotic. That shouldn't surprise us. 1 in 10 are nurse prescribers, so 1 in 10 of antibiotic prescriptions that we see are written by a nurse, and that's on the rise. And over 75% are access antibiotics, and again, I'll go over that later on. So really positive in primary care. Now acute hospitals. 16% rise in antibiotic use over the last 5 years. So a little bit of work needed there. IV antibiotics accounts for 1/3 of all antibiotics in acute hospitals, and 59.7% are access antibiotics. So that's not miles away from where we would hope it would be. But again, I'll go over that later. So that's in acute hospitals. In October this year, the Chief Nursing Officer issued us all with a letter. You've maybe seen this letter. And it detailed healthcare-acquired infection standards and antibiotic use indicators that we all have to meet within Scotland. Okay? The first one of these is in primary care, and I'm not going to focus too much on that today. I'll focus on the second two. One looks at our intravenous antibiotic use, and it can't be any higher in 2022 than it is in 2018. And the other one looks at the WHO access antibiotics, and I'll go over that in a wee while. So how are we doing? How are we going to target where the work needs to be done? So if we look at the second one, this is the intravenous antibiotics that we're using in secondary care. So do we have any idea of how we're doing in Tayside at the moment? We do. So we've got data here till the end of 2018 broken down by board, and we are second from the right. So for all, Tayside is quite a high user of IV antibiotics. That doesn't matter as far as the target is set. The target sets that we can't be any higher in 2022 than we are at 2018, so that's where we are in 2018. That doesn't give it any kind of quality measure around is any of that prescribing appropriate, or could it be shortened, or what could we do? All we need to make sure for the target's point of view is that we don't go higher than that. Okay? I wouldn't like to be Glasgow. The third one is the WHO access antibiotics. So the WHO made a list of antibiotics, and they categorised it into three lists, and it was called the AWARE list. There's access, there's watch, and there's reserve. And it's basically a traffic light system, if you can think of it like that. Access is green, so that's the ones we are promoting that you use first line empirically on our policy. Watch is ones that will allow in certain situations. They may appear on some guidance across health boards, and reserve are ones that really shouldn't be there, and we would question why they're used, and certainly ID or microbiology should be involved. So Public Health England looked at that list and made our own UK list. So one of the targets is that 60% of our antibiotic use should be from the access part of that list. And again, how are we doing so far? Do we have any sense of how we're doing? So that's Scotland perspective. So access antibiotics across Scotland are rising. The trend is going up, which is really positive. And by board, again, we've met that target already, which is really good. So again, we're second from the right, and we are only one of the few boards that has already met that. But that doesn't mean we can give up. That means we've got 3 more years to make sure that we don't lose that and that our access antibiotics remain as what we're using first line. So it's good, but we can't become complacent. That is the list. So that is our aware list split into access, watch and reserve. And even within the access list, there's probably some curveballs in there. We don't really use fusidate. We very rarely use tetracycline. There's a few in the watch list that we use quite frequently, like coamoxiclav, clindamycin, Vanc. We still use them relatively frequently. But can I just draw your attention to what's at the very top of the reserve list? Aztreonam. We'll go on to that later. So that's what we're working towards. That's what one of the targets is asking us to look at. So that's where our policies should be leaning towards, that access list, that first column. So if we look back at stewardship within Scotland, we've kind of had 3 ages. It's gone in 3 distinct pieces of work, if you like. The first thing way back when SAPG was formed and Scotland Act was first written was, what are we prescribing? It was very much stay away from the 4 Cs, we're looking at C. diff rates, stay away from broad spectrums, and that was the message that we were giving out. And that's still true today, that hasn't changed. We then moved on to work looking at whether we should prescribe. Is anything self-limiting? Are we giving antimicrobials for viral infections? Is there work we can do around that? Now we've gone on to a piece of work looking at duration, and we're trying to bring durations back, so shorter is definitely now better with far as antibiotic prescribing. But our antibiotic use is still rising. So where are we going to go next? What are we going to look at next? What is next for antimicrobial stewardship across Scotland? And that's where we are now. We're starting to think about that. I don't know if any of you have seen that paper. It was quite an interesting paper. I think it was on Twitter as well. It looks at how we communicate the public health risks of drug resistance and antimicrobial resistance with the public and what language we used, and is it miscommunicated? Are we making healthcare workers and the public understand the risk of antimicrobial resistance? And it actually compared it to smoking cessation in a way, because it looked at the second-hand effects, if you like, and could it be compared to smoking cessation? Now, obviously, they're totally different. Smoking kills millions of lives, antimicrobials save millions of lives, but actually there's this second-hand effect that affects members of the public, even if they've taken it. So it looks at if you're living in the same neighbourhood as somebody on an antimicrobial, if you're in a nursing home, and the risks associated and how that can be communicated out. So that's one way of thinking of antimicrobials, and moving forward, how we communicate to the public and engage with the public to get them on board. Now, I spoke earlier on about One Health and antimicrobial use in animals and the environment. Can I have a show of hands in the audience of who has a pet at home? Okay, so 19% of vet consultations on the high street will end up in an antibiotic prescription. Okay, by tonnage, animal use is by far the biggest use of antimicrobials that we have across Scotland. And yet in the last 5 years, they managed to lower their antimicrobial use by 53%. That's massive. That's absolutely massive. So how did they do that? What can we learn from the sales of antibiotics in food-producing animals? What can we learn from that piece of work that the Scottish group can take forward? Now, a lot of that will be finance-driven because there's commercial companies, but there must be some learning that we can take on board from that, because that's massive. I hope you all know who we are. We're bringing it back to local now, so our local antimicrobial management team, some of us are here today. There's input from all specialties in our team, and we do work very closely together with the lab and infection control, and there's contact details on there. So if there's anything at all, please engage with us, or we'll come and find you. So wouldn't it be an antibiotic talk if I didn't mention Aztreonam? It's a bit of a hot topic at the moment. It's been raised to many managers for many reasons about the use of Aztreonam. So I thought I'd better raise it today. Aztreonam is a restricted antibiotic. It's restricted as per the WHO list, as per the Public Health England list, and as per SAPG. Okay, so it's something that we should not be using routinely. First choice in Tayside is, and has been for a while now, gentamicin. Per protocol, so as long as you use it appropriately, it's gentamicin is our first IV gram-negative agent. Okay, there are massive resistance implications if we overuse Aztreonam, and we're not going to have that in the future. And actually, when you look at the spectrum of Aztreonam, it's not a like for like. So Aztreonam does not have the same cover as gentamicin. Okay, it is not as broad as gentamicin. We don't like to put a pound sign within antimicrobial stewardship, but if you did put a pound sign on it, if you take a patient on an average dose of gentamicin and compared it with a treatment dose of Aztreonam, it's around about 25 to 30 times the cost per day on therapy. So financially, it's significant. Okay, and I think that's why it was brought to the attention of lots of people within Tayside. Because of this, we carried out an audit across the surgical floor. We did it over a 2-week period, and we got 32 patients on Aztreonam across the surgical floor. A whole range of indications, some of which seem sensible, some of which maybe not so much. When we looked at what the patient's EGFR was, so were they eligible for gentamicin, could they have had at least one dose of gentamicin, 85% of patients who were on Aztreonam could have had at least one dose of gentamicin. Okay. When you look at some of the reasons why Aztreonam was given and why it was inappropriate, patients could have already met the IVOS criteria. They could have been eligible for gent, but actually when you looked at their news score, there was possibly no infection concern there at all. Okay? So that was our initial audit that we carried out. Busi produced this visual, which is actually sometimes easier for people to remember some of the learning around Aztreonam. So it highlights some of the key messages that can go up in ward areas. It can be put anywhere that we think would be helpful, and hopefully it will help address some of the Aztreonam issues. We presented this information to OLT, which is the Friday morning meeting. There's a short life working group convened, and we are looking at Aztreonam and how that can be managed, and other stewardship issues, because Aztreonam is not the only issue that we are dealing with, and how that can be managed through all the clinical governance groups. So that's something that we are working on at the moment. The history behind Aztreonam, I think, is important. So back in 2014 and 2015, the national target for us was to look at Pip-Taz use and Carbapenem use. And it was the target for us to lower Carbapenem and Pip-Taz use, so broad spectrum agents, as far as we can. And we managed to be the lowest users in Scotland. We were the lowest board for those two in Scotland. And that was because after gentamicin therapy, if you still needed an IV gram-negative agent, we were going for Pip-Taz or a Carbapenem, and what we did was we pooled that, and Aztreonam found its place there. So that's where Aztreonam was brought into Tayside, to replace Pip-Taz and Carbapenem use. But if you look at Carbapenem data, this was from 2018 into 2019, so this is current use of Carbapenem. We have sustained that 4 years later, and we are still the lowest mainline health board of Carbapenems today. So that's really positive, but that's why Aztreonam was brought in. If you look at our Pip-Taz versus other health boards, again, we're not doing too badly at all. Okay. Now, there's going to be niche areas where meropenem and Pip-Taz are absolutely appropriate, but we have managed to sustain keeping those two agents down. Okay, so that's where Aztreonam came from. The ongoing work that we're carrying out within the stewardship team, it's never ending, but some of the things we do, we look at guidelines that we make, we engage with all clinical specialties, so if there's anything that you feel out there that we can help you with, please engage with us, please come and find us. If you find any antimicrobials that are being used in a novel or non-formula use, let us know, because it's helpful for us when we're horizon scanning if we know what's going on out there. because a lot of antimicrobial use kind of goes under the radar because it maybe doesn't raise any alarms financially because it's a low-cost item, but if you let us know what's being used, that would be really helpful. We're doing a lot of work around durations, so shorter is absolutely better, and we'll be looking at policies on policy review and all of our durations and see if we can look at that. There's a piece of work being going on for some time now around penicillin desensitisation and the accuracy of allergy and how it's documented in people's notes and what a true allergy is. So that was a national piece of work. There's a national flowchart now on how you can delabel, how we can work with these people to get the penicillin allergy removed if appropriate. And there's a pilot going on in Ward 3 in 9 Wells looking at that. Now, there's a piece of work going on in UTI. Joe was leading on that, and it's looking at, can we remove urinalysis as a diagnostic tool in the elderly patient? Can we just stop doing urinalysis on these patients as per national guidance? Okay, I'm sure it drives us mad, I'm sure it drives you mad, but urinalysis is carried out inappropriately in lots of occasions. So that's been piloted and carried out in P&K community hospitals. We're hoping to spread that into Dundee and certainly pilot that hopefully in wards in 9 Wells. So that is ongoing. Joe and I also carried out a stewardship round on Perth site. So what we did was we went to Perth every Friday for 3 weeks and we did a full PPS of all wards and we looked at all patients on antibiotics. We found 73 patients who were on antibiotics, 53% of which required an intervention by us. So that intervention could be they're ready for IVOST, we can de-escalate, do they even need an antibiotic at all? But 53% of patients on an antibiotic needed some kind of intervention from the stewardship team on the Perth site. So that makes us think, is there a need for a stewardship round elsewhere? Can we look at doing some of that in ward areas in 9 Wells? So that was quite interesting for us. Again, another piece of work we looked at was TTO work. So TTO are to take out antibiotics. They're over-labelled packs of antibiotics with pre-labelled instructions and quantities inside the box. Now, some of them were out of date. A lot of durations, as per national guidelines, have been shortened. So what we did was we looked at TTOs in stock lists in 9 Wells and in PRI and in out of hours and in minor injury units, and we revamped all of that and we removed everything that wasn't necessary. So that was a huge piece of work. And again, we engaged with the OPAT team, who hopefully you're familiar with, routinely. Lots of pieces of work. I thought it would be useful to include that information because when we implemented News 2, we had News previously. There was a feeling that because we are initiating antibiotics within the first hour of the sepsis pathway, that could lead to an increased use of IV antibiotics. And how does that sit from a stewardship perspective with our national targets that we have to meet? So this piece of work was carried out, and it actually shows you that IV antibiotics used within wards in Tayside from 17 to 19 before and after News 2 was introduced, and there was no change at all. So if you look at the usage before and after, if you trend line that out, it hasn't gone up at all, which is really positive. That implementing News 2 in Tayside has not done anything to our IV antibiotic use, as some of the literature was starting to say. So that's quite positive. So I've mentioned Joe. Jo McEwen's here today. If you don't know Jo, you should know Jo. She is our ANP for stewardship. She does a huge amount of work engaging nursing staff out in the ward areas. She works in community hospitals, acute hospitals, to engage with the stewardship agenda. And why she does that is because the largest professional workforce within healthcare is our nursing teams. Okay, they by far outnumber the medics and the pharmacists that we have. They regularly review and have engagement with the patients. They are the constant at ward level. Rather than the medic, again, or the pharmacist, the nurse is the constant. Their primary role is to administer medication safely and effectively, and it's in their duty of care to ensure patients receive the correct medicine. So what is the correct medicine? Per policy, per guideline, that's appropriate for the patient and the patient's needs. So that's part of the nurse's role already, without giving them any other duties. This paper came out in 2015 and it looked at some of the stewardship functions and jobs that would be needed by various members of the team, and the nurse was the only one that ticked all the boxes. So if you looked at pharmacists, medics, infectious diseases, the nurse was the only one that does it all or could do it all. So we really should work closely with our nursing team. The areas where nurses can influence, they have a huge remit: duration of therapy, sampling, reviewing results, health promotion. There is a massive remit there that nurses can get involved in, and almost every one of them fits nicely into our targets that we are working towards. Monitor duration of therapy. They can ask for a review, they can look at how long it's going on, they can ask things for to be discontinued, and again that fits nicely into our targets. So they are really, really important. The standards now for the nursing education and standards, so undergraduate nurses will have the theory of antibiotic prescribing in their course now. They will not come out as nurse prescribers straight away when they qualify, but within a first year they are eligible to take up the practical elements of prescribing within a year of qualification. Okay? I'll move on. If you look at how much nurses prescribe in primary care across Scotland, it's rising. So nurse prescribers are prescribing more and more antibiotics year on year. In fact, there's been a 124% rise of how many antibiotics nurses prescribed. But when you look at what they prescribe, 86% of that is access antibiotics. So nurses follow guidelines. Nurses, according to this, prescribe appropriately. That's a really positive result. And as per the SONAAR report and our 5-year action plan, we all need to work collaboratively. Okay, it needs to be a team effort. We need to share learning. We all have equal responsibility, and we all have a way that we can influence stewardship. And I will stop there. Happy to take any questions. Thank you.
Thank you, Heather. I think will we turn off YouTube?
Yes, please.